All this is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. Today we have a rock star from UK, Dr. Tina Pierce. She has a Pierce protocol for long COVID. I am honored to have her with us. She was participant for the context purposes. She was a participant and presenter in Dr. Tess Laurie's conference, Bird Conference. She has now her own conference coming up next month as well. I am honored to be part of that conference as well. Dr. Tina Pierce have now been managing COVID long haul patients for some time. So here is a quick introduction to Dr. Pierce. So she is a women's health specialist. She has been helping COVID long haulers since November of 2020. Prior to that, she has been managing mast cell activation syndrome patients for 6 years. So here the important thing is the mast cell activation syndrome patients, because one aspect of the long haul patients is mast cell activation. So that is a very important area that she is working in. Dr. Pierce, welcome from me and from all the cool beans.
Thank you so much for inviting me. I'm very honoured indeed to be able to speak to you because you are an absolute rock star yourself. And so it's a great pleasure to be able to share our ideas and discuss what we're doing in in America, in the UK. It's a fantastic opportunity. So my background is I trained as a GP originally, and I did general practice for 7 years, part-time, while I had my 3 children. And then I realized that my great passion was women's health. So I became a consultant in contraception, actually. And I put together the services, contraception services for the whole of Surrey. For 24 years, I led that and really enjoyed that. That was fantastic. And at the same time was developing menopausal services and became a menopause specialist. So I now have the menopause consultancy where I work with 4 other doctors, and we see menopausal women and help them to stay healthy and fit and well, which is fantastic. And I also have an interest in mast cell activation, as you quite rightly say, Dr. Mobeen. So that interest comes from my daughter, actually, because my youngest daughter is now 28, and she has been ill all of her life, and we couldn't work out what was going on with her. We couldn't find anybody who could help us with her, and she just became sort of stepwise more and more ill as she got older, and as she had infections like swine flu, she became more ill. She then became hypothyroid, became more ill, and then had chickenpox as a 19-year-old, and so on. And then she became super ill in 2016, and I was so concerned. I had to really sort of trawl through the internet, try and work out what was going on with her. And that's when I made the diagnosis of mast cell activation syndrome in Jessie. And then I had to try and find somebody to help me. And that was really, really tricky. I couldn't find anybody in London. And I stumbled across a fantastic Professor Vic Coular, who is a urogynecologist and at St Mary's Paddington. And he confirmed to me that I'd made the right diagnosis. And then he has really been my mentor and helped me with Jessie and with my patients to work out what's going on. Now, then once you know about something, you can't sort of unknow it, can you? You can't help yourself, but then start seeing it and hearing stories of people and thinking, oh, I know what you've got mast cell activation. So I started diagnosing about 7 people a week. Coincidentally, they were coming to me for the menopause or for contraception, and I would take their history and think, oh, they've got it too. And then I would say to them, I think I know what you may have causing your IBS and your chronic headaches and your urticaria and so on. And the most common response I had was that they would burst into tears because they were so relieved that somebody was interested in all these funny symptoms that they had and was putting a name to the problem and trying to help them with it. So that's where my interest in mast cell activation started. And then I didn't ever advertise that fact, but people just come to you, don't they? And I just got busier and busier with that. And then in last summer, I started hearing more and more about long COVID, long haulers, and the symptoms that they were struggling with. And it just rang bells with me. And all of the symptoms seemed to resonate with, mast cell activation. So I thought, this is what's going on. Their immune system is responding in this way. It's either exacerbating the precondition of mast cell activation syndrome, or it's somehow causing it in them. And so I wanted to find out, curiosity being the fantastic, and I went on BBC television, a local television station for BBC, and I asked the long COVID patients if they would download a free app called the People With app, and that's written as one word, and they could put in their profiles, their symptoms, and record them. And 2,000 people did, and I could look at their profiles, and lo and behold, they absolutely matched the profiles of the patients with mast cell activation. So then I thought, I need to speak to these people, and the best way to speak to them is to actually open a clinic and start seeing them. I also felt I could help them, and it was immoral not to try and do that. So I opened a clinic, and actually it was fully booked very, very quickly. And I started because I wanted to ask the patients, as well as helping them, I wanted to say to them, what was your previous history like before you caught the coronavirus? And did you have a history of allergies, IBS, etc., etc.? And by far the majority of them have had that history. So they've got a sort of previous predisposition, if you like, genetically to having mast cell problems. And then the coronavirus, just like any virus, made it much worse. And then I started treating them. And so many of them have got so much better. Some of them are completely better. Some of them are 90% better. They're able to get back to work. They have just a few residual symptoms maybe, but they're manageable, or they're completely better. So it's very, very exciting and very good work to be doing. But I've been inundated, and it's actually difficult there's such a huge demand. There are other doctors like me in the country doing it. Those who already treat MCAS have recognized the similarities and what's going on. Some nutritional therapists and also functional medicine practitioners, they are treating patients with long COVID as well. But unfortunately, the NHS has been very slow to catch up with what we're doing. And they have opened long COVID clinics. 70 long COVID clinics have opened across the country, which is pretty amazing, really. But unfortunately, they're telling people to pace themselves. They refer them to a cardiologist to be checked out for their POTS type symptoms, and then they're referred to a gastroenterologist who checks out their IBS type symptoms, and then they might see a neurologist for their tingling and their headaches, but they're not being offered any treatment as such. So that's been disappointing, really. So on the back of that, I decided I needed to organize a conference, which you have honored me in coming to speak at, which is fantastic. Thank you. I thought we should have a conference so that we can put out there what some of the leading people are doing in this field to try and spread the word to patients and doctors alike, to just get the message out there.
Awesome. Such an amazing story, starting from your own family and all the way, a continuity of service throughout. And for the cool beans, a couple of things here. Number one, from an administrative point of view, if I'm looking here, please don't think that I'm losing contact with you or with Dr. Tina Pierce. I am looking at the presentation that she would be talking through. And if I'm looking here, again, not making a content, these are the contact. These are the comments over here. So I'm looking at the comments to see what questions I can present. So the request that I can make for the cool beans here, if you can put QQQ or some question marks with your questions, so I can filter them from the question stream over here and present them. We are live at 5 channels at this time. So there are many questions that come from all those channels. So having said that, going back to Dr. Tina Pierce, Dr. Pierce, this is such an important area that there are folks who are asymptomatically healed. I am seeing that even they are becoming long haulers too. So long hauler does not actually have a target to say that a person must undergo following symptom sets during the disease to become a long hauler. Anyone can actually end up in a long hauling state, and that is the sad part of this. Second part, as you're talking about NIH as well, doctors actually do not know how to manage the long haul. Many times in the beginning of the pandemic, when people started having long haul, doctors would simply say this is psychological. I
Yeah.
had guests here on my program who
Yeah.
simply said this was psychological and
Yeah.
people should stress less and they would become okay and we should give psychiatric drugs. So thank you very much for highlighting it. Thank you very much for working with it. Thank you very much for the conference for it. I think this is a tragedy at this time. An important thing is these folks can actually be, these patients can be cured or brought back almost towards normal.
Yeah, absolutely, absolutely. So one of the problems is that mast cell activation isn't well known about. And had that been on the radar of GPs and doctors in a clinical medicine setting in hospitals and so on, it would have occurred to them. They would have recognized it. But because it's not known about, and they haven't been taught about it, they don't discuss it, they don't read papers on it, they just sort of pass them by, and so it seemed absolutely tragic that patients, for example, with acute COVID aren't treated immediately. From the beginning of this pandemic, I have been saying treat people straight away. As soon as they catch the virus, treat them as if they have mast cell activation. Get things they can do, which they can buy over the counter in many countries. So the antihistamines and the supplements and ivermectin in some countries, and they can take those and protect themselves from getting worse. But it's very strange that the medical profession generally has been sort of sitting on its hands, and it hasn't been helping these people until they're really in a bad state and having to be admitted to hospital, which is then obviously much more difficult to sort out the hyperinflammation that's gone on. But so mast cell activation was put together as a syndrome in the 1980s, and it was only given a name in the 1990s. And it was in 2007 that the first three case studies were published, actually had a publication. So it hasn't been taught, and it's not, as I say, there are no randomized controlled trials, never mind good ones. So everything that we're doing is consensus and sort of expert opinion of those working in the field. So it's a very new science. And therefore, people don't know that when patients come to them with IBS, that they've probably got mast cell activation. When they come with fibromyalgia, they've probably got mast cell activation. When they have chronic headaches, they've probably got mast cell activation. And so these patients are not. They can spend decades with a poor quality of life and no help and no diagnosis. Not being looked after properly, which is, I'm hoping that the silver lining of all of this pandemic and long haulers and everything is that that this is now putting it on the map. The landscape is going to change. We are having the conversation. We are putting it out there about these conditions, these hyperinflammatory states that people find themselves in, that are affecting a very high percentage of the population. So we reckon as much as 17% of the population probably have some mast cell dysfunction. And therefore this is really important. This is groundbreaking, I think, to get this information out there. And so it's very exciting. And my dream would be that these long COVID clinics, which are currently just telling people to breathe and relax, will become centers of excellence for patients with fibromyalgia, chronic fatigue, Ehlers-Danlos loss, POTS, etc., IBS, because mast cells at the center of all of that.
Wow, thank you so much for doing this. I can actually see probably a couple of people within my own family, immediate family, may need actually help with the mast cell activation syndrome. So having said this, let's see if we can go over your presentation.
Yeah.
Because I'm already seeing the questions rolling in. So I think let's have your, are you ready with the?
Yeah.
All right, let's roll with the presentation then. So let's take this one off and this one off. So here is the presentation. So cool beans, once again, please hold on to your questions for for a few minutes. We're going to go over the presentation and then we'll have an open discussion. Please, Dr. Pierce.
Okay. So do you want me to bring my slides up on my screen?
So let me actually bring them up.
Bring
I have them.
You have them? Yeah.
I have them. So
Okay.
let's do it. 1 second, please.
Thank you.
Here we are.
Thank you. So these are the slides. I helped organise the International Ivermectin for COVID conference, which was in April, and Dr. Drbeen was our chairperson and did a presentation at that, which was fantastic. So these slides are from that the presentation I did at that conference. So I haven't changed the title slide yet, but I will do anyway. So this is me, and the next slide, please. Okay, so the hypothesis is that the cause of long COVID is that the acute COVID exacerbates mast cell activation syndrome in patients who already have the condition, which up until that point is probably unrecognized and untreated. Now, going with that hypothesis is that actually if they had been treated and had been on the medication to control their mast cell activation syndrome, they would have probably had less in the way of, first of all, acute COVID symptoms, and then also less in the way of long-haul COVID symptoms. So that's the first bit of our hypothesis. And the second bit is that acute COVID-19 actually causes some mast cell activation in the minority of patients with long COVID. So we think the majority have got a pre-existing problem, and the minority maybe have no pre-existing problem, but it exacerbates it. So the etiology of mast cell activation syndrome is environmental, it's genetic, it's viral, and it's epigenetic. So if it's viral, this is where somebody who has normal mast cells, it can be stimulated, and the mast cells can be really upset by the virus, which then results in mast cell activation syndrome. But the people who have already existing mast cell activation syndrome have got some genetic mutations. And there are over 50 KIT mutations in patients with mast cell activation. And probably patients don't just have one mutation. They probably have a combination of a whole load, which make their mast cells super excited and a little bit too reactive. The third part of the theory is that viral persistence in some cases is continuing to elicit the immune response that is causing the mast cells. But we now think there isn't viral persistence, but it's viral debris. And Dr. Drbeen, you can talk a bit more about that because we've had discussions about that, haven't we? So allergies are very, very common. 1 in 5 people worldwide has allergies. And allergies are based in some kind of mast cell activation. 1 in 10 people have urticaria, 1 in 5 have allergies. It's becoming more and more common that people are allergic. 10% of preschool children have food allergies, which is like unbelievable. When I was a little girl, we used to go to parties and you could have peanuts on the table, but now there are so many things that you can't have out because one child could have an anaphylactic shock. So allergies are becoming much more prevalent. The other thing to say at this point about mast cell activation is that it's much more common in women than men. So 80% are generally female, which I noticed somebody commented on one of the comments saying, is it more common in women? Yes, it is. So next slide, please. So, as I said earlier on, it's frequently seen and seldom recognized, and therein lies the pity. It's very common. Up to 17% of the population are estimated to have these dysfunctional mast cells, and all you have to do is think about your friends and family. Do you know anyone with IBS? Probably yes. Do you know anyone who's had some funny sort of headaches, chronic headaches, and has to avoid various triggers, can't have wine? Do you know people who flush bright red when they have wine? And they say, I can't have takeaways, or I can't eat this, I can't eat that, I've got various food intolerances, and etc. Or people who have funny rashes, who really react to insect bites, and sometimes wake up with a swollen face and swollen lips, have hives, people who have fibromyalgia or psoriasis, rosacea, eczema. These are all patients who've probably got some mast cell dysfunction. And it causes chronic inflammation in various different systems. And so it can be multisystemic, and it can change. In one person, it can be in one system, and then it can be in another system another time. So it can be confusing. And usually all the tests are normal. So it's actually very difficult to come up with a sort of biological biomarker kind of diagnosis at the moment. Now, I think that's going to change. And I think that's going to change because of Dr. Bruce Patterson and his laboratory, which is really exciting. So I feel like we're on the sort of precipice of something very, very exciting happening here in this field. But up until now, I haven't really been able to do any blood tests and things on my patients that are particularly helpful because of the laboratories that we have in the UK. So we can do their diamine oxidase blood test, which has to go to Belgium to come back to have retested. But you know, all the other tests, the labs don't know how to handle the samples. They have to be chilled from the moment you take the blood. It has to be chilled. It has to be chilled in a centrifuged in a chilled centrifuge, and none of the labs I know have that. So it's very difficult to get anything other than a clinical diagnosis. But to be honest with you, the clinical picture is so becomes so familiar once you start working in this field that you can feel pretty certain that that they have got this condition. And the symptoms themselves are actually caused by cytokines and amines that are released by the mast cells. So the mast cells, as you've said so many times on your lovely talks, release over 1,000 different chemicals and mediators. So there's cytokines and chemokines. So the cytokines are mediators that are messengers between the cells, and the chemokines attract inflammatory cells to the area. And then you've got prostaglandin D2, you've got histamine, heparin. I mean, there's just such a huge list of chemicals. So it's not surprising that if these are a bit dysfunctional, these cells, they're going to be releasing sometimes a cytokine storm, and sometimes possibly just selective chemicals in a dribble drabble kind of way, which are irritating the body and causing inflammation. So next slide, please. Okay, so I was thinking about this from the beginning of the pandemic, and then so some colleagues in America, in your country, Afrin, Weinstock and Molderings, they did a fantastic publication on September the 10th. And this was in the International Journal of Infectious Diseases. It's really worth a read because they cover so much about mast cell activation in that publication.
And you will be, my apologies for interruption,
Yeah.
You'll be happy that I have discussed Afrin's paper with the cool beans in depth. So they're aware of it.
They're very familiar with this then, which is fantastic. So I'm sorry, I'm preaching to the converted, which is fantastic. So the hyperinflammation seen in the COVID-19 is absolutely consistent with MCAS. This was their theory. Prevalence is similar to that of MCAS in severe COVID. So it's about 17% of patients who catch the COVID-19 who have it severely, and that would fit with the 17% of the population having dysfunctional mast cells. And then drugs that inhibit mast cells and their mediators do show promise and actually do seem to do quite well with COVID-19. Now, this is completely anecdotal, but I don't see acute patients with acute conditions. However, I have come across about 10 patients, friends and family, and a couple of patients of mine who have had very severe COVID, and they've been so ill. A couple of my patients came onto Zoom calls for their appointments for the menopause consultancy, and they couldn't talk to me because they were coughing and coughing and coughing and coughing. They were in such a state, and with a high temperature and sweating, and they just looked terrible. And they, I said to them, right, we're not going to talk about HRT and the menopause. What we're going to talk about is how to get you better now. And I asked them to go on antihistamines, to take some various supplements. So that's the vitamin C, D, zinc, selenium, magnesium, quercetin, and then and also I prescribed type 2 antihistamine because that's prescription only in this country. And all of them within 24 hours were starting to get much better. So much so that some of them had been in bed for 10 days with these awful cough getting worse and worse and worse. And then within 24 hours, they were up, getting dressed, getting showered, and feeling no cough at all. So absolutely dramatic results. It's only 10 and it's anecdotal, but very interesting that, and some of them actually had a lot of comorbidities. So one friend of the family, he has cirrhosis of the liver and heart disease and diabetes, and he was really very sick, but within 24 hours he started to feel better. So that's just an aside. Anyway, so yes, so their theory fits absolutely with what I'm saying. And none of their patients who have mast cell activation who caught coronavirus had it severely, and none of them died, thankfully. So because their mast cell activation was sort of under control, they actually fared rather better with the acute infection. And so they were hypothesizing that that dysfunctional mast cells actually underlie the severe acute and chronic COVID-19 illness. So next slide, please. Then there's this paper by Brca in Cambridge University, and they published in January 2021. And this is that they felt their research showed that the likelihood that severe and long COVID is established early in the stages of the disease we should be taken into account, and that we were missing a trick and we should be treating it early, which was what would fit with the mast cell activation hypothesis as well. So they said that people who were asymptomatic or had mild disease, it was characterized by a robust immune response, and then their immune system set back to normal very quickly after the infection, whereas those who admitted seemed to have an impaired immune response and severe inflammation as a result of that. And those that got better, it continued to overreact, and the cytokine storm persisted, and so their cells didn't seem to go back to normal. If you could go to the next slide, Dr. Drbeen, that'd be lovely. So so there wasn't the quick resolution that was seen with the patients who had it mildly and moderately and just seemed to get over it very quickly. But there was a persistence of abnormal immune cells, T cells and B cells, and some of them actually, even after limited recovery, didn't get back to normal, which suggests they were abnormal in the first place. So I thought that was a really interesting paper for people to look at. Okay, next slide, please. So what did I do? Well, I opened, as I said earlier, I opened my clinic, and I opened it on the 1st of November, and I put it into my diary until the end of March. And within 36 hours, it was completely booked up. Now, I already had a very busy schedule, so I could only do one morning a week. So it was, gone starting at 8 in the morning and going through till sort of 1 o'clock, and back-to-back patients. And so I've now seen about 75 long COVID patients, but when I did this slide, it was 60. 8 were men and 52 were women. So it's predominantly women, and 58 had a previous medical history suggestive of MCAS. And so some of them had considered that, these people consider themselves often to be very healthy, and they manage to exercise and everything, but they've always got IBS, and they have to be careful what they eat, or they have to have various food intolerances or whatever. So it can be quite a mild background pathology, but it is there. But there are 2 who had no previous history whatsoever. No matter how much I looked, I couldn't find anything that suggested that they had any allergies or anything. And I suspect then the virus has caused the mast cell dysfunction for them, which presented as the MCAS. But and they interestingly got better much more quickly than the others. So few adjustments, and they were really on their way. And all of the patients, I'm in a very happy position, I suppose, that by the time the patients come and see me, they have been fully investigated by a whole load of specialists. So because everything is siloed the way we do medicine at the moment, it's not a holistic approach, which would be much better in my view, but currently everything is siloed. So they've seen a cardiologist for their tachycardia and their palpitations and their low blood pressure, and everything was normal. and then they'd seen a gastroenterologist and maybe had some biopsies taken and colonoscopies and etc., and it was all normal. And they'd seen neurologists and so on and so forth. So actually, it's I'm in a much safer position when they come to see me then, because I know I'm not missing anything else. And one always has to remember that people with mast cell activation can also have other pathologies. They can also get cancer, etc., etc. So one has to keep your radar open and alert for that at all times. So there were only three had a diagnosis of myocarditis, but everyone else's tests were completely normal, apart from the odd eosinophilia or raised C-reactive protein or something like that, but nothing dramatic. So next slide, please. So these were the typical symptoms, and I am sure any of your viewers who have got long COVID will completely relate to this list. And they would have IBS type symptoms, so abdominal pain, diarrhea, nausea, vomiting, bloating, food intolerances, sometimes terrible constipation actually as well, which needs to be really sorted out, because that's terrible for the reabsorption of the toxins, which then have to go around their system again. They had various dermatological problems. So itching is a very big feature, sudden redness, flushing on the neck and the face, rashes would appear and then disappear, dermatographism, which is when you can write on your skin and you can see, you could write your name across your forehead and it stays there for 20 minutes. Worsening of eczema, worsening of rosacea, worsening of psoriasis, or starting of rosacea. Then they could have various cardiovascular things like palpitations, vertigo, arrhythmias, hypotension, be diagnosed with POTS, Crohn's disease, which is it's angina without any plaques. And this is something that actually my daughter had when she was 7 years old. So when she was 7, she started complaining of severe chest pain, which would last a few seconds. And it was really quite alarming. And her description of it was just like angina. And we had her completely checked out. But now we know that when her histamine goes very high, she sometimes gets this chest pain, and she recognizes it as a type of angina. Then running nose, sneezing attacks, asthma and shortness of breath, then headaches, migraines, sweating, freezing, menstrual pain. Some of these symptoms can be triggered by the most extraordinary triggers, like walking from a warm room to a cold room. They can suddenly come over all dizzy or start sweating or whatever. Fibromyalgia, tingling sensations. A lot of patients with long COVID have talked about tingling sensations, and a sort of tremoring in their body, especially when they go to bed. They feel like their whole body is tremoring inside, and they can't see anything. They haven't got a visible tremor, but they feel it inside. It's like their nerves are all jangling. Brain fog is a very common problem. So I find, I have to make my letters to their GP, which they get a copy of, very clear, because I know they won't remember half of what I said to them in the consultation because of the brain fog, and then I get loads of emails. Can you just clarify this, clarify that? Because they just can't remember. And then anxiety. Now, the anxiety is an interesting one, because when the histamine is very high in the body, which it will be if the mast cells are activated, the body responds by trying to bring the histamine down. And one of the things it does is it releases adrenaline to do that. And that causes terrible anxiety and panic attacks. And this is people who are normally calm and say, I don't worry, I'm not that kind of person, I'm really not anxious. And then suddenly they feel really, really anxious, like, there's a lion that's going to pounce and get them. Insomnia is a big one, because again, histamine is very important in the circadian rhythm. Fatigue and post-exertional malaise, which is really disappointing, because as people start to feel better and then they want to get back to their runs or their cycling, they then come back and they crash out for 2 days because they've increased the histamine release by exercising. So next slide, please. So what do we do, right? This is what you all want to know. What do we do? So we have I do put my patients on a low histamine diet, because I have found it helps 99.999% of the people. And therefore, it is the sort of first thing that we have to do. It's not so bad. I've been on a low histamine diet for the last 3 months, and it's been a very interesting experience because it's made me creative with my cooking and think about all the different tasty things I can do, which are low histamine. So it's a very healthy diet. It's a very nourishing diet, and it's a very tasty diet if you're imaginative with it. And it's a lot of vegetables, a lot of fruit, meat, protein. So it's fine. There's just certain things you can't have, which maybe you love, but you can't have. And then we give type 1 antihistamines because the sort of treatment in mast cell activation is to avoid the triggers. So that includes diet triggers. Then to reduce the release of the mediators. And that would be steroids, non-steroidal anti-inflammatories, and vitamin C. Now, obviously, we don't like to use steroids very much because of all the horrible side effects, and they're not a sort of long-term solution. Some patients find non-steroidal anti-inflammatories helpful, but some don't. In some, it actually makes them worse. So we have to be careful with that one. And then you want to you reduce the release, the production of the mediators and the release of them, and then you want to reduce the effects of them. So that's why we go for the type 1 antihistamines. And we ask them to very patiently go through the different types of type 1 antihistamines to find which one is best for them, and it will be different for different people. So that would be loratadine 10 milligrams 3 times a day, or cetirizine 10 milligrams 3 times a day, or fexofenadine 180 milligrams 3 times a day. And so one has to patiently try each one of those for maybe a couple of weeks, and then decide. If you, at the end of 2 weeks, you think, has this helped me? Do I feel any better? And you're having to ask yourself that question, then the answer is no. Then try another one, because when it does help, you'll know. It does. You do start to feel better, and you think, this is the one for me. And then we also then add some type 2 antihistamine, and we try and add one thing at a time and change one thing at a time, so we know whether what is the good boy, the good guy, and the bad guy. Otherwise it's impossible to tell. So that would be famotidine, which is the most powerful type 2 antihistamine that we have, 20 milligrams twice a day, nizatidine. And then we go through the mast cell stabilizers, which are also antihistamines, but they seem to stabilize the mast cell rather better than some of the others. So rupatadine 10 milligrams at night. If somebody finds that helpful, I then ask them to try it twice a day, and because some people that can be a game changer. If after doing it twice a day for a few days there's no difference, then we go back to once a day. Ketotifen is a very useful one because it makes them very sleepy. So if they're not sleeping well, it can really help with the sleep. But they might have to titrate up very slowly to the 1 milligram dose, because it can make them feel like they've got a hangover the next day. So you have to let your body get used to it and do it very slowly and gradually. Sodium chromoglycate, particularly if they have gut issues and tenderness. And then quercetin, which is one people can buy over the counter, 500 milligrams 3 times a day, can be very helpful, actually. Apart from that, we then go to probiotics. So vitamin C, probiotics are really important. I actually, very interestingly, what I've been doing with my patients, Dr. Drbeen, is I've been getting their genetic testing done for their histamine pathways, their methylation pathways, nutrition report, and their estrogen pathways. And so we can sort of try and drill down and see how else we can support their system. Because it appears that, and this is going to be presented at the conference actually by my colleague Emma Bezic from LifeCode GX, it appears that the patients with mast cell activation and the long haulers, they seem to have more than the general population problems with certain genetic variants. And these particular genetic variants are ones that mop up toxins and help the body to stay in balance. So it's almost like the perfect storm. They're producing more toxins, and then they don't metabolize those very well or cope with them very well. And therefore they get the inflammation, the toxins persist and cause alterations in their dysregulation of their homeostasis and so on. So it's very interesting. So we do that so that we can drill down and see if they need extra manganese or zinc or whatever it might be. And we also do their gut testing. And that's been very interesting. And my colleague Debbie Cotton is going to present the findings in our patients at the conference as well, which would be great. And that will be, because a lot of them have got dysbiosis, and many of them have also got parasites in the gut, which is going to be revving up their immune system all the time. So clearing all these things out has been very helpful. So we give them probiotics, vitamin C, slow release, 1,000 milligrams a day, vitamin D3, niacin. I like the no flush one. I know there's a big debate about that. I'm sure you've been involved in that debate. But I don't like flushing.
I wanted or not, I have been involved, yes.
Yes, it's a big debate. And then selenium and zinc and magnesium. And then ivermectin, which I'm now starting to prescribe. So Dr. Drbeen, you and I have been involved in trying to put together a protocol, haven't we?
Yes.
For long haulers using what they should take, and that includes ivermectin. So I've started, as of the last 2 weeks, I've managed to source some ivermectin in the UK, because that's been our big problem, is getting hold of some. And we've managed to get hold of some. And so I've actually told them to have, maybe not enough, but 0.2 milligrams per kilogram for 5 days, and then weekly for 4 weeks. So I've got about 10 patients now who are ordering it from this source, and then we're going to see how they go with that, which will be
just a quick anecdote over here.
Yeah.
One of my patients from last year, March, April timeframe, she's a medical student. Now she's in final year, almost a doctor. She developed COVID. I managed her. She developed some cardiac issues with hydroxy, blood pressure variations, and tachycardias. So I stopped in the middle, but fortunately we had helped her enough that she bounced back and she was fine. About a few weeks ago, she reached out once again. Her aunt had gotten COVID.
Mm.
So while talking about how to manage her, she mentioned that her own issue now was that she was not able to focus correctly on her studies and not able to sit up for a longer period of time. So she was myalgic, she was fatigued, she was nervous, confused, not able to focus correctly, and just weak in general. So she said, something has happened to me. And she had no clue that this is long COVID. There is another tragedy that is happening in some of the countries where the idea of the long COVID has not even reached there. So she didn't know that this is long COVID or post-COVID syndrome. I diagnosed it immediately, and I said, why don't you start taking some ivermectin? So she took ivermectin for 3 days. And then I asked her to call me again. And my thought was I would have to give her a steroid pulse therapy as well. So when she called, without asking, my bad, without asking that, hey, how are you doing? I said, so we may have to start with steroids too. And she responded and said, I am fine. Ivermectin has fixed it. So why do I need to have steroids? And I was so surprised that she was suffering that for a year. And just 3 days of ivermectin changed the game for her.
Amazing. It's amazing. So I mean, I'm really excited to be prescribing it now, because I think it's got a key role, and it's part of the cocktail that we should be, doing for these people. And what's been very interesting is a lot of my long COVID patients have now been better than they have ever been for decades, because they've had undiagnosed and untreated mast cell activation, and now it's being treated. So I had one lady who was suffering from diarrhea 8 times a day. Can you imagine? Diarrhea 8 times a day for the last 10 years. And as soon as she started the famotidine, her diarrhea stopped within 24 hours. So now she has a normal stool once a day.
Wow.
And you can't believe it. I mean, imagine the impact on your quality of life. If you have to have diarrhea 8 times a day, you can't go on a long journey, because you'd be worrying about toilets and stopping all the time. You can't go and just shop, and you'd always be thinking, where's the toilet? Where's the toilet? It'd be so embarrassing. Even if you went round to friends for dinner, you'd be popping off to the loo and thinking, can they hear me? It'd be just awful. I mean, the whole thing. And she was so grateful, and she couldn't believe it. And other patients who've had, again, long COVID patients, who've had funny symptoms grumbling along in the background for decades have found, they no longer have headaches, they no longer have their fibromyalgia type symptoms, they no longer have got their itchy skin and scalp at night that drives them crazy, and the insomnia that stops them sleeping. So that's been a sort of bonus, really, I suppose, a silver lining for them. But anyway, the other thing I do recommend is the neuroplastic retraining of the amygdala and the insular parts of the brain. And I refer them to the Gupta program, and Ashok Gupta is actually going to also present at the conference. And I think this has a very important role to play in helping these patients get out of that vicious cycle of feeling unwell and their immune system anticipating, really, that it needs to keep being on red alert. So instead of ignoring triggers and just letting the body get on with its business, these mast cells have become so super sensitive. They are jumping at every chemical trigger, every food trigger, etc. And they just need to be calmed down. And you can use your conscious mind to calm down your subconscious mind. So that's been really helpful. And we've had some dramatic results with that actually as well. So next slide, please. So when patients haven't responded so well to all of those, and some people don't, and the other thing that can happen, which can be very trying and difficult, is some of the patients become so sensitive to chemicals that they can't take the drugs because of an excipient that's in the drug, or there's a dye that's in the tablet or something. And so we have to try different makes. That's worth doing. And we also have some specialist pharmacies that will mix together, and dispense some very pure forms. But the problem with that, though, Dr. Mubin, it's so expensive for patients. I mean, these pharmacies are, really, really expensive. So you have to have a sort of trust fund to be able to fund you going through, all medications from them. And I do have 1 or 2 patients who literally have to have their medications made up specially for them. But we are getting there because they're getting some goodness now. Some of the chemicals are getting in and they're tolerating them and they're helping their mast cells to calm down. Then we've got montelukast, 10 milligrams a day. Beware, because about 30% of people can get depressed on that. So just be aware of that. LDN, low dose naltrexone. I've had some amazing results with this, especially with the tingling and pain. I had one lovely fellow who's a lawyer actually, and he had terrible pain in his feet, so bad that he could hardly walk, but his feet are totally normal. But this pain, this neurological pain, was just awful. And within about 24 hours of starting the low dose naltrexone, his pain is gone. Just so dramatic, amazing. And then diazepam, 0.5 to 1 milligram twice a day. People don't become addicted to it because it sits on the mast cells and it's taken up there. It can't give them it hasn't got addictive properties for these patients. Just like if you're given morphine for pain, you don't become a morphine addict in the same way. And then SSRIs. Yes, and I talked about how important the gut health is, and getting rid of the parasites and the dysbiosis, and treating any other infections. So I've got patients who've got things like fungal infections in their feet, chronic infections that are going on and going to be constantly stimulating their mast cells. So we need to calm and treat everything we can, get rid of infection. Interstitial cystitis is another one. It's 80% of people with mast cell activation have female, 30% have interstitial cystitis, and 30%. So no, 80% have hypermobility.
Wow.
So yeah, so it's it's a very new burgeoning area of research. But there's so much. If somebody's interested in doing some research, there's so much that can be done. What I'm really excited about is that we need improved diagnostic techniques. We need to be able to run the biomarkers, find out what's going in each patient, because they'll be different. These patients have got different genetic mutations, therefore they'll be releasing the cytokines in different patterns, different quantities. And if we knew that and we could see what those are and profile them to the genetics of the patient and their symptom profile, then we could see which is the best treatment for them straight away, rather than the trial and error, which we're sort of doing at the moment. Well, I know I'm doing at the moment. That if we could drill down and have those diagnostics and the biomarkers, and then we could sort out the targeted therapies, couldn't we, for them, which would be amazing. And I feel actually with Dr. Bruce Patterson's work, we're getting so close to that. For the first time, we're going to get close to that, you know.
Yes, so Dr. Yo and Dr. Bruce Patterson, the in-cell diagnosis, and again, just for the disclosures, we do not have any commercial interest with them. At least I do not have any commercial interest with them. I hope the same thing for you as well, Dr. Pierce. And his work is excellent. And I think it is groundbreaking. And as you have said it a couple of times as well, the labs that he is working on, they are going to become the important guideline for MCAS management.
I think so.
Yeah. And this, Dr. Pierce, when you were talking about it, I was thinking about my patients, my friends. There are people, you're correct, there are people who have gone through this disease or this syndrome for decades without being diagnosed and without being treated well. And they have just taken it as their life is destroyed that way. And I was seeing with COVID, this was happening as well, that there are people who are actually giving up, saying, this is not going to go away now. This is with us. This is how I'm going to be now. And I see this so much in the youngsters who are so depressed that, hey, I used to be healthy. I used to exercise. I used to do this. I used to do that. And now I cannot do anything. So thank you so much for your work. And I want to add one more comment. My apologies here. For the cool beans, if you may have noticed that the doctors who have appeared on this show, they have a unique difference from other doctors, and that is they are thinkers. All of them. If you talk about Dr. Paul Merrick, Dr. Corey, Dr. Stephen Phillips, Dr. Jalali, Dr. Antinatos, Dr. Pierce over here, anyone who has been here, you would identify it very quickly that they have been thinking. So please realize that at this time, and this is my statement, my opinion, I don't think that this is Dr. Pierce, or I don't want to put this on her. I feel at this time there are two types of victims of COVID. One that are actually the victim of the SARS-CoV-2 itself, and then the other one that are the victims of the doctor's ignorance or refusal to learn and understand and do research. So thank you so much, Dr. Pierce, for being the one who is thinking and researching and figuring it out. Back to you. My apologies for the interruption.
No, that was great. That was great. I'm very grateful to you for saying that. That's very kind of you. But I think that, I mean, the patients who've come to me with long COVID, they have been languishing on their sofas, not being able to be parents to their children, not being able to work, and it is pretty miserable for them, especially when they then go to their doctors, their GPs, who then say, well, there's nothing we can do for you, go home. And it's like, surely there must be something, you know. It's so frustrating for them. So I think that we have given them a sort of lifeline, really, and not just me. I mean, all the doctors who are doing this, and the functional medicine doctors, and the naturopaths, and the homeopaths, and everyone who's trying to help these people. It's a big joint effort, really, which is fantastic. When we come to exercise, I recommend that patients do things like yoga and Pilates and weights, so they don't actually get their heart beating too fast. And I'm sorry if somebody loves running and the high that gives them, or you know, the endorphins, etc., that it releases. But at the moment, it's probably not sensible to do that. And so they do lots of weight training and things like that. And so they can keep physically fit, and they can keep their muscles and their strength, but just not go on the treadmill, basically. And they find they can do that, which is good. Yeah. But yeah, it's very exciting, and it's very humbling, actually, when you ring people and they say, I'm so much better. It's so lovely.
Absolutely. So tell me this. Thank you so much for this. Are you ready for some questions as well? Do you want to?
Yeah, do my best.
Okay, perfect. So what you would see is that the cool beans here, I think that cool beans, tell me if I'm wrong, I think this is the most informed in terms of medical mechanics and the concepts. This is the most informed group that we have here. We have a smaller group compared to many other folks who talk about COVID, but very deeply aware of the mechanisms of the body. So we can actually talk much more openly and much more clearly in terms of medical depth and still go with that. So Cool Beans, I know that you had been putting some questions out there before, but this is the time that we're going to go over some of the questions. So Dr. Piers, once again, thank you for your time. And I'm going to start asking some questions that people are asking. So Denise TG, so is there a question? Okay, let's go over the natural mast cell stabilizer, quercetin, and so that seems like a comment. Thank you, Denise. We have Rupesh Singh. I'm having tingling sensation around my right eye for the last 15 days after COVID recovery. Am I suffering from post-COVID long haul? Blood report had lipoprotein A very high, around 104.
Highly likely. Highly likely, yes. People can have blurring of vision. They can have deafness. They can have tinnitus. There's a lot of people suffering with tinnitus, so it can affect the nerves, the nervous system, definitely. And you must remember that histamine is a neurotransmitter. And also some of the cytokines and mediators that are released, we don't even know what they do. We haven't even yet figured out what they do. So it's highly likely, and these are patterns and symptoms that we have seen before.
Got it. And talking about histamine and serotonin, I think you would enjoy speaking with Dr. Fareed Jalali as well. Have you had a chance to speak with him?
No, I haven't. No, so, tell me more.
So he's here in California. He's a gastroenterologist, but once again, he's that curious person who started thinking and researching. And please, in Dr. Corey's word of go back to doctoring. Doctoring doesn't mean that if you have become specialist in one area, now you cannot think about another area. It is doctoring, doing research, figuring it out, what would help the patient. So Dr. Fareed Jalali started doctoring, and he started trying to figure out what is going on. So he appeared here on our show as well. He's a big proponent of, hey, there are things with histamine, with serotonin that we need to take care of. And he has a paper as well. I'll send it to you. 150 slides that he presented here, talking about various symptoms and how there are the bases within the histamine and serotonin abnormalities. So I think you would enjoy speaking with him too.
Oh, do send me the slides. That'd be fantastic.
Absolutely, yes, absolutely. I would connect you with him as well. So 30415 says, is there also a role of food enzymes?
Yes, so there is actually. So diamine oxidase is made by the body to reduce the histamine absorption from the gut. And you can buy DAO supplements. It's called Daocin, I think, the one we have available here. And it's helpful to patients who are going to eat out. Especially now we're opening up in this country, so people are starting to eat in other people's homes and they're going out to restaurants again. And where you can't control necessarily exactly how much histamine is going to be on your plate. So it's useful to have a couple of Daocin tablets 20 minutes before you eat. Also Toxaprevent. I don't know if you've come across Toxaprevent. It's a zeolite, and that can also absorb some of the histamine out of the food for you, so you don't absorb it. And those kind of little tricks are helpful. Then the other thing that can happen in histamine intolerance and mast cell activation is that patients can get pancreatic insufficiency. And when we do the gut testing, we can see whether they're actually not producing enough in the way of enzymes, pancreatic enzymes. And if they're not, giving some supplements of those can be really helpful. So often these patients have, yellow, funny stools that float and difficult to flush away and things like that. And then you give them sort of Drbeen, Thorn Drbeen, or some other digestive enzyme, and they transformed. Their stools are transformed, and obviously then they're absorbing much more of their food and so on. So it's really helpful. Yeah, so they do have a role to play.
Got it. Next question. Jimmy Lowe says, Dr. Pierce, have you discovered any neuropathy specifically related to postmenopausal women with BRCA reactive history having tingling or neuropathy pain in breast?
No, this is the first time I've had that question, actually. I haven't come across any patients who've had that particular symptom. I do see a lot of Brca patients and women post breast cancer who have decided they'd like to have HRT. Often they've tried all the alternatives to help with their symptoms, menopausal symptoms, and they haven't done very well with them, and therefore we end up going on HRT, and that can completely transform their life. But I haven't had that particular symptom. No, I haven't come across that. Sorry.
Okay. No worries. Thank you very much. Colin Hamill, he's actually from UK as well. Hamill, if I'm correct, you're from UK, correct? Hemi, we have been actually talking before as well. So he said, Dr. Bean, how do you always manage to get the best guests? Well,
oh, I'm very flattered.
I mean, the doctors that go the extra mile showing how they care. Dr. Tina Pierce, thanks for all you do and your energy.
Oh, thank you. Thank you.
I think what happens is when the times are hard or dark, lights shine out. So these doctors are like lights. I have talked with so many doctors, my friends, my class fellows, my colleagues, peers, and I have requested them to look into some of these studies, new papers, and new ideas. And they just simply say that, hey, I go to my clinic, I practice what I know, and I have been practicing for 20 years, 30 years, 40 years. This is what I know. This is what I'm going to practice. And then there are doctors like Dr. Tina Pierce here, Dr. Corey, Dr. Stephen Phillips, Dr. Jalali, Dr. Syed Heather, and the list goes on. These are like lights at this time. They are the ones who will be then deciding in the future how these diseases will be managed. They are the ones who would be written in the books and with their protocols and with their help. This is just natural, and I am proud and I am humbled that we have such guests with us. I'm very, very happy with that. Because at the end of the day, this talk that we are doing, Dr. Pierce over here, at the end of the day, this helps people, right? This 1 hour of the discussion is going to translate into millions of hours of watch time, which would then allow people, doctors to learn how to manage this and patients to become aware and then seek help accordingly.
I hope so. I hope so. Well, I mean, that's one of the reasons why we put together the conference, which is on the 19th and 20th of June. It's open to patients as well as to medics and health, clinicians, healthcare professionals, whatever your training. If you're interested in it, and we've got some fantastic speakers, haven't we? Like yourself, your good self, and also Dr. Lawrence Afrin, who's going to be talking about mast cell activation. And it's a great opportunity to hear people like this speak. And we've got Bruce Patterson talking about his research and what his findings have been, and then Professor Cavallo from Argentina talking about treating long COVID patients with ivermectin, and then my colleague who's going to be presenting the genetic findings, and the other colleague with the microbiome. So we're really, really lucky. We've got a great lineup. I hope people can join us, because the whole idea is spread the word. Let's get it out there, to help as many people as possible.
Absolutely. Thank you very much. I'm going to continue with some more questions as well. I know that we are 1 hour into it. I appreciate your time. We all cool beans appreciate your time. So here is the next question. So Rupesh has already asked it. Bambi Secret is actually from UK. Thank you to all the doctors you've had on your channel for quick thinking and giving their time. Thank you very much, Bambi. And Bambi was putting a comment that she herself is right now going through some of the tests which may be related to this. Sunshine Bean. Could undiagnosed MCAS be the cause of severe vaccine side effects? Would zinc, quercetin, vitamin D, and C help to lessen severe side effects?
Well, that is hypothetically possible, that it could make people react to the vaccine. So what I've been telling all my patients to do, and all my friends and family who aren't MCAS or long haulers, is to take antihistamines the day before their vaccine, and to take these supplements, and then the day of the vaccine as well to take them. So in fact, my son, I've got a son who's 33, and he's going to have his first vaccine on Saturday, tomorrow, and he sent me a text last night, Mum, what should I do? And I said, right, this is what you have to do: get some quercetin, get some, I've already given him, he's got fexofenadine, and he's got and he's got some famotidine. So he's going to take those, and he's going to take the quercetin, and let's see. I've had 2 vaccines, and I took those for the day before and a couple of days after, and I didn't even have a sore arm for both jabs. So it's worth a try.
Got it. Thank you. Doug Gross, he's a regular Cool Bean. Are you, Tina, are you okay if I told Cool Beans your bean salutation?
Yes, you can.
So Cool Beans, Dr. Tina Pierce has chosen Binu as the Cool Bean title. So, thank you very much for that. So Doug Gross, so many symptoms, labs, possible treatments. Is there a systematic approach?
So yes, I mean, I always give people the type 1, the type 2 antihistamines and a mast cell stabilizer, and then the vitamins and minerals as a basic. And then we go from there. And for some people, that's enough, and the low histamine diet. What we're hoping with Dr. Bruce Patterson's approach is that we will be able to run some blood tests and say to people, oh, you fall into this category, or you fall into this category. Or we might even get to the stage, once the research is done, where we know certain symptom profiles are caused by certain biomarkers and results, and that they will therefore respond to certain treatments. And therefore we could go from the symptoms to the treatments. And if people can't afford to have all the bloods done and things, then we could just miss out that step if we know the profiles. So that's work in the future. But at the moment, the systematic approach is low histamine diet, type 1, type 2 antihistamines, mast cell stabilizing, avoid the triggers, take your stack of your vitamin stack. I think they're calling it, the Facebook groups and Twitter and everything are calling it the stack, because I've been putting it out there when I give to people to try and just, let's help as many people as possible. I'm very I'm a technophobe really, but I've been forcing myself to tweet occasionally and Instagram and things like that. And it's fascinating how it gets, it does get the word out, doesn't it?
Got it. Thank you very much. And Doug, just to add on to that as well, I am also working with Dr. Pierce here, Dr. Yo, Dr. Folks on the FLCCC as well, to put together an algorithm for management of long haul. I believe that algorithm would further be augmented with the labs and other things, and it would keep maturing and evolving.
Yeah.
So I would say approach is evolving, and it would continue to evolve.
Yeah.
Scarlett Monahan says, is there an antihistamine that can be used to treat the cytokines?
So it's worth trying them all because they will block. I'm not sure that they'll block the cytokines per se, but they will block the histamine on the receptors, won't they? I mean, there are other drugs that will block cytokines, won't there? Which ones the tyrosine kinase inhibitors and things. They will inhibit the cytokines.
Got it.
Yeah.
This is more of a comment than the question. Omok Lamok says, I post the treatment posted here in this channel on Facebook, and they blocked me. So that's just an extra.
Probably because it mentioned ivermectin.
So my Twitter, so right now you are on a feed on Twitter as well. So we are on Twitch, Twitter, couple of Facebook channels, and YouTube. And Twitter would, soon after this is over, they would come back and they would just remove it. So but there are other challenges than just to look at the disease and manage it.
Okay.
Colin Hamill says, Dr. Tina Pierce, would you consider moving your practice to Carnlow?
Where's that? Where's Carnlow?
Yes. Where is Carnlow? Tell us more.
Tell us where it is. See if you can entice me.
Yes. So Louis Grant says, a colleague who received 2 times Moderna vax experiences dysregulated menses and persistent areas of acne or dermatitis. Is this related to long haul MCAS, and what would be good first approach to this?
I don't know if that's related to something, just a reaction to the vaccine per se, or whether there is some MCAS going on there. I'm not sure. It's early days and we haven't got any research at all or data on patients having the vaccine and having reactions and which groups they sort of fall into. I think, that's very unfortunate, isn't it? There have been quite a few reports of the vaccine causing changes in menstrual cycle, but it's very difficult to quantify that, because women do have funny menstrual cycles sometimes anyway, don't they? You'd have to have quite a large number of patients to prove and try and see what was going on there. So I don't know the answer to that question, I'm afraid. Keep
Got
on
it.
asking.
Got it. Thank you. Bilal, New Jersey says, Doctor, I'm one of those who are suffering from J&J vaccine reactions for 47 days now, leg pain, brain fog, tingling sensation. Is this treatment could be vaccinated over reacted people lifesaver as well? So
I think if you've had those kind of reactions, those look like MCAS symptoms, don't they? I think it would be worth your while trying our approach and looking at our long haul protocol that we've worked together on and with some others, and have a go at it, because that does look like mast cell activation symptoms, the brain fog, etc., that you described.
thank you. And just to, so my wife is usually, she does not like her information to be more openly discussed, but with her lots of permission, I have been talking about her J&J vaccine and what happens afterwards. She still has joint pains and she still has GIT, sometimes upset and tiredness. To me, it seems like she also has so she used to have these symptoms before, so maybe she had MCAS, and it looks like the MCAS has flared up since the J&J as well. So I'm going to actually have her watch this video as well.
Good.
John Rias says, Benadryl effective?
Very, very effective. Yes, some people, that's the one for them. Yeah, try it.
Excellent. Thank you. Naveen says, does bromhexin act as an RDRP inhibitor? Any comments on the same?
I don't know is the answer to that. Do
Yeah.
you know anything about that?
Yes. So we talked about bromhexin, Naveen, in the past as well. Bromhexin is a protease inhibitor.
Right.
From that point of view, it should actually inhibit RDRP, but bromhexin does not enter the cell to go do that. Instead, it works with the TMPRSS2 that is present on the surface of the cell, and that is how bromhexin, in theory, in mechanism, is able to help reduce the SARS-CoV-2 function. Now, there have been studies that I also discussed afterwards that showed that bromhexin may have less effect, and then camostat mesylate or some other drugs which are similar class may have more effect.
You see, I think you've got the brain as the size of a planet, actually. I do. It's just amazing. You're amazing.
Thank you. I think what happened was, and I have discussed it many times, what happened was I saw a paper. So Dr. Pierce, there was a paper, fake paper, somebody wrote in which they said, Stanford doctors say, do the following and the COVID would not impact you. And the things were totally messed up, totally wrong. And somebody forwarded that to me and said, can you comment on this for me, that should I do this or not? And that was just BS paper. And I thought people would do this and they'll become severe and they'll die. So that was the time when I actually took up the case of talking about COVID related things.
Well
and
done.
It just kept going from there. So it was not even a plan to say, I am going to come out and I'm going to do this all. It was just an intent to say, man, this is going to cause some. And tragedy is that my own friend's brother was following that paper's protocol, became severe, ended up in ICU and died. He died because it was too late. He had been doing what that paper had said. So it happened to some. So this was the basic driving factor.
Frustrating.
So some more question. Rajendra Raj Purohit says, Dr. Pierce, is there any relation between plasma therapy and vaccine with virus new variants?
I don't know, actually. I think the plasma therapy is only working in people who are immunosuppressed. Isn't that right?
Yes.
That was the latest study that I saw. Do you have anything else to add to that, Dr. Mabeen?
So, Raj Purohit, plasma therapy and vaccines with the virus with the new variants. I know that Japan has said that we're not going to take plasma from those who are being vaccinated. I have to actually look up what is concerning them, and we would talk more about it after I have done some studies. Pammy Cubine says, how in the world do MCAS and fibromyalgia and chronic fatigue patients differentiate between their normal bad flare-ups and when they catch COVID? It's a blue.
Yeah, so when they catch COVID, they're normally signs of a viral infection. So they get symptoms which are more than their normal fibromyalgia, et cetera, and then they so they have the fever and the cough and all the sort of typical things that might occur, and then it's just afterwards they may not, it just grumbles on and on and on. So the fever may go, or they may feel better for a few days and then it comes back, and then sometimes their MCAS original symptoms flare and are made worse as the sort of cytokine storm grumbles on, or becomes a rain shower, as Dr. Bruce Patterson describes it. So it's not as bad as it was, but it sort of just keeps grumbling on and on and on. So usually they can tell. I mean, I have, MCAS patients who've said to me, I was like this, and then I definitely had coronavirus, because then I was bedbound and I had fever and so on. So you usually know. And of course, in the early days when people were catching this, we weren't testing them, so we don't know if they were positive or not. So, but the symptoms and the story fits. Yeah.
Got it. Thank you. Couple of more questions. Scarlett Monahan says, is there an antihistamine you would recommend? What is type 1 and type 2 antihistamines?
So I think my list has got them there for you, really. The ones that we recommend. I think it's a shame we can't use ranitidine anymore. we used to millions of people across the world were using ranitidine quite safely. It was absolutely fine. So so you might want to just take a screenshot or have a look at this for your type 1 and type 2 antihistamines. And I mean, I've only put 3 on there of the type 1 antihistamines. There are more, but those are the ones that are readily available for us here in the UK. So they're my sort of go-to ones. But then, you can add Benadryl and etc., Piriton and so on. And some people find, as I say, one better than the other.
Got it. Thank you very much.
Yeah.
So
Yeah.
one more question. I know it is 1 hour, 18 minutes now. One more question. Natural Sounds says, following treatment, will we be able to exercise again? Also, would you recommend trying a 3-day course of ivermectin?
I anticipate that after everything has calmed down, you will be able to exercise again. Now, the mast cells that have been around during this troublesome time will be hypersensitized and overreactive, and then we will calm them down. But mast cells can last several months, and even some last a few years, unfortunately. So until you get rid of all of those and the new ones that you're making are coming into a calmer environment, you could still anticipate a few problems. But I have got patients who are able now to go on bike rides and to pick up the exercises that they were doing before without suffering too much from that. But they do understand that they can't do that and have spaghetti bolognese for supper, because that's just too high histamine on top of exercise. So they're becoming aware that they have to just titrate themselves carefully, really. And some of them don't have to stick to the low histamine diet forever either. They will, as things calm down, they'll be able to introduce some histamine, more high histamine foods, but they'll have to be careful to keep everything under the threshold, because if your threshold is here, you want to keep it below, otherwise above, and you're toxic, and then you get your symptoms again. And there are certain things. It's very interesting. Our modern diets are just so histaminic. They really are. We've got people are all having fresh coffee, which is a diamine oxidase blocker and very high in histamine. They're having green tea. They're having loads of cups of tea. Is that you? And they're having more alcohol. than we used to, I think. And that, again, is a diamine oxidase blocker. And chocolate, unfortunately, one of my great loves, but there you are. And so people, on modern diets, and then they're having spinach, avocados, tomatoes, and we're eating everything all year round. We're not eating it seasonally anymore. So people are having, avocados on their toast for breakfast, and they're sticking in their salad for lunch, and then they might even have some in their supper, and it's just like too much histamine, too many TV dinners, leftovers, processed foods. We've got to get back to basics and being healthy with our diet, seasonal, locally produced food. I'm sure that's where we need to head, really. Anyway.
Absolutely great. And I'm sure we have a cool bean, Dr. Nick Ariza. He's a physician as well, and he talks a lot about the diet and balanced diet and diet-based therapies. So thank you very much. I'm sure he's very happy hearing this. So Dr. Pierce, thank you so much for your time and for your insights. I believe that these are the tiny lights. 1 hour of a discussion can actually change a whole generation's new issues that we are seeing. So thank you very much for doing this. Thank you very much for bringing this to us.
It's my complete pleasure. Thank you so much for inviting me and for doing what you do, which is just amazing, getting the words out there.
Thank you.
Fantastic.
And thank you very much from all the cool beans here. There is so much. You can actually read those comments as well. There are so many people who are thanking you, who are sending hearts to you, and who are just very happy with this.
Oh, that's nice. Yeah. Thank you. What a lovely audience you have.
Yes. So thank you very much. And cool beans, we're going to take off now. And thank you very much. I will see you this evening.